Mm-mm-mm. Alrighty, good afternoon, everyone. Today, I'm very excited to be hosting this session. And as always, thank you all for joining us in learning more about medicine and getting your expanding your knowledge. It is with great pleasure and excitement that I would like to introduce our guest physician for today, Dr. Catherine Toomer, who is a family medicine physician and will be sharing her journey towards medicine and also towards her specialty of family medicine. Just a reminder, if you guys would like to get the hours for today's session, our Google form link will be posted in the chat, and you have to get 70% to get your hours counted. Without further ado, I would like to introduce Dr. Tomer for her presentation. Doctor, whenever you're ready.
Okay. Hello. Like you said, I'm Dr. Toomer, and I'm a community health and family medicine physician. And so I'm just going to go ahead and just get started since the questions pretty much speak for themselves. And let me do this next. So, um, the first question is, what was my journey to medicine, and what made me want to go into medicine? Well, when I was 8 years old, my father was diagnosed with colon cancer. Now, I was 8 and I really didn't understand what that meant. I just realized that there was a lot of tension in the house. People were sad. My father was different than what he normally was like. He used to travel a lot with his job. Suddenly he was home and going back and forth to doctors and to the hospital, in and out. And so I knew he was worried. And I could tell my mother was also worried. And then all of a sudden, that worry went away. It just seemed like it was gone. So I asked him, what was going on and what happened? And he said, I had colon cancer. Doctors found it very early and they took it out. And now I'm fine. He had surgery and I didn't even know, and so I remember thinking, well, and I asked him, well, what would have happened if the doctors hadn't found it? He said, well, it's something that could kill me. At 80 years old, I understood that cancer could be deadly. And so when I heard that, I thought, well, I want to be a doctor because they saved my father, who is like the world to me. And so I told him right then and there, I said, I'm going to become a doctor. And he said, okay. And the next thing I knew, my mom, who was a teacher, presented me with this box about a week later, and it was a put together skeleton, and it was anatomically correct. So I mean, right down to the kneecap, the patella bone. I mean, and so it took me almost a month to put it together. But the fact that I said I wanted to be a doctor, and they took me seriously, I was like, that's it. I don't think I've ever considered anything else. Um, and then when I was about 12, almost 12, my family moved to East Africa. And what I saw there were a lot of people on the streets who were beggars, and many of them had diseases that um, had gone untreated. Things that normally in first world countries would not even exist, or would have been treated early. So I saw a lot of river blindness. I saw, a lot of malaria, um, even though that, is a cyclical language. I mean, sorry, disease.
Mhm.
Um, and I saw, uh, what we called elephantitis. I think now people refer to as elephantiasis, but it was very common, and it's a type of roundworm disease. I saw a lot of that. And so I started realizing that there were people who were poor who were getting sick, but the people who were rich were not. And so I started understanding that there was a disparity in care based on socioeconomics. And so as I got old, and I lived in Kenya from the time I was 12 until I was going into my second year of university. So I grew up really seeing this and understanding what it meant. Um, and I also was in the British education system, and they streamline you very early in that system. So by the time I was 14, I had to decide if I was going into the arts or the sciences. I loved the sciences, and so that's where I went. And so it seemed like every part of my life just sort of fed into becoming a doctor. And so that's what made me interested. And then I started my undergraduate degree, what I would consider a gap year, in that it really didn't go towards anything. I just took classes just to keep my mind occupied. And it was, just a lot of electives. And that was at the university, US International University in Nairobi. And then during that year, I was applying to schools in the United States. And my family was originally from Michigan, so I applied to Michigan schools and got into Michigan State. And once I was there, biology just seemed like a natural course to go into to become a doctor. And so I graduated from the College of Natural Sciences, and I then applied for medical school. And interestingly enough, I was not accepted. My first, when I got interviews, I and I just didn't get in. And my favorite school was the school I actually just was about to graduate from. And so I went to the admissions director at the med school and I asked her, I said, why wasn't I not accepted? And so she pulled out my folder and she went through it and she said, you know what, Catherine, I don't have an answer for you because I know there are people in this class that have the exact same grades, the exact same extracurricular activities, all the things that you have who are in this next year's class and you're not. So I don't know what to tell you. And so she said, give me a couple of weeks. Let me see what I can do. And so what happened after that, I got, oops, that's my residency. I'll go back to finish my story. so I, so 2 weeks later, I actually got a letter saying that, she said, I can't get you into this year's class, but what I can do is get you into an interim program, a post-baccalaureate program, where if you maintain a certain GPA, you'll automatically get into the next year's class. And I was like, of course I took it. I mean, anything that was going to guarantee me getting into medical school, I would take. I didn't care what it took. And so actually I was entered into that post-baccalaureate program before I even graduated. So I was able to take medical school classes before I graduated from undergrad, and I didn't have to repeat those classes once I got into med school. So that meant my first year of med school is going to be simpler than for everyone else. So it was a win-win as far as I was concerned. And I knew that, like, now 25 years later, nobody cares if I didn't get in right in. It doesn't matter. It feels bad at the time, but it really makes no difference. Um, and so um, after I went through medical school, I knew even before going into med school that I really wanted to be a family physician. I wanted to be able to do as much as possible anywhere as possible. I assumed I was going to go back to Africa. I wanted to have a background where I could take care of anyone and everyone. And so when med school came to an end, I applied for residency programs and trained at the University of Florida in Gainesville. And one of the beautiful things about that program was that we were the only residents in our hospital, which meant that we're called what's called unopposed. And what that meant is we didn't have to compete with other residents to get experiences. So any surgeries, any procedures, all the things that all the education that every doctor in that hospital would give all came to us. And so that was wonderful. So any children that came in, we took care of. It wasn't passed off to pediatric residents. Any surgical issues that came in, we took care of. It wasn't passed off to surgical residents. And I really wanted that experience um, because I thought I was going to have to do much more hands-on family medicine. And so I just didn't want it watered down. And so how I became a family physician. So I talked a little bit about already the steps. So I started as a pre-med biological science student. I got very involved in campus activities, including sitting on the Dean's Council. And that actually is what got me into med school. And the reason is the assistant dean of that council ended up the admissions director of the medical school I wanted to go to. So she knew me when I walked in the door. And Sometimes it is about who you know. And in my case, that was actually the case, um, sadly. But it wasn't that way for everyone. But I was also very willing to do anything I had to. And so when she gave me an option, I took it. And so I took my MCAT. Please don't ask me what it stands for. It's been too many years. I can't tell you. But I took it near the end of my junior year, and I applied to medical school beginning of my senior year. And one of the things that I would always advise is apply early. Most medical schools have rolling admissions. The earlier you apply, the easier it is to get in. And what rolling means is they fill up the class as they go along. So they get a little more picky towards the end of the process. So always apply early, um, and apply often if necessary. And so I applied at the end of my senior year. I got accepted into the post-bac program, like I mentioned, before graduating. And so since I was already technically in the med school, I was taking med school courses. We would take one med school course a semester, and the rest would be undergraduate courses. Almost all of those courses I'd already taken. So to me, it was just review. Um, and so I could just focus only on the med school course. And that was very helpful. But I also, because I had that year, it also gave me time to think about how I was going to pay for it. And one of the things that I found out was that because I absolutely knew for sure I wanted to go into a primary care field, I could apply for the National Health Service Corps scholarship. And what that does, it pays for all of your education. It gives you a stipend for each month. It pays for all your books and everything. I mean, I didn't, it was a full, complete scholarship. And all I had to do was to work in an underserved area for every year that they paid for school. That's exactly what I wanted to do anyway. So for me, again, it was a win-win, and I got the scholarship. And so um, I applied, got the scholarship, took and while I was in school, did everything I could to come in contact with every family physician I could. Anything that was related to family medicine, during rotations, during practicums, I just jumped at it. Any volunteer opportunities of working in community health centers, anything I could do just to expand my knowledge, expand my exposure. Um, and so while in medical school, then we applied for the match. And what the match is a system where you apply to residency programs, you go around and you interview, and then they rank who they want, and then each student ranks who they want, and then they try to match the rankings. And so I was by that time I was married. I married while in medical school. I wouldn't advise it, but we're still married 27 years later, so I guess I can't complain. Um, and so we went through the couples match and matched in Florida. My husband, we met in Michigan, at Michigan State, both of us in the post-bac program. And he's from South Carolina, and we knew we wanted to move south. And so we applied to those residency programs. So we got in to the University of Florida. He matched in radiology, and I matched in family medicine. Um, and we got our second choice. Our first choice was the University of Alabama, and the only reason it was our first choice was because it was closer to Atlanta, and we had more family there. That was the only reason. But actually, the University of Florida, it was a better program, so we didn't mind that we got our second choice. Um, what is family medicine? Well, like we say in the South, you take care of everything from the rooter to the tutor, which basically means from head to toe. Well, actually, not so much head to toe, but you know what I mean. So essentially, what we do is we take care of everyone from the cradle to the grave, from conception to the grave. So in family medicine, we do obstetrics if you want, we do pediatrics, we do adolescent medicine, we do procedures, we do adult medicine, we do end of life care. Um, we work in nursing homes. Just every single thing in medicine that comes up that is not a technical field, we do. But even with technical stuff, we still do minor surgeries. We learn about radiology. We cover emergency departments. So we just do a lot of things, and really, it's wonderful because you can do as much or as little as you want in within the field. Um, and so my approach to family medicine is what's called a biopsychosocial approach, and that was what we did in med school. And what that means is we focus on the biology of the person, the psychology of the person, and the sociology of the person, meaning their family, their friends, and how that affects their health, their psychology, and how it affects health, and of course, your biology. Um, and so, what that does is it puts family medicine in a position to problem solve for symptoms. It also helps with health maintenance because, once people are well, you want them to stay well. Or if people are well, you want them to stay well. And then also for disease prevention. And so within that, within family medicine, so we also do a lot of educating as well. And do stuff like this. We always get asked to do, which is wonderful because, you know, most of us are very, very enthusiastic about our field. So it's always great. Um, and with medicine, it is a very broad um, field. It covers a lot. It covers everything, and it can become overwhelming for some people. And I know a lot of people who've left family medicine and gone into something more specific like ophthalmology because they'd rather just focus on the eyes, or cardiology because they'd rather just focus on the heart. Whereas we just do everything. And so it's kind of like we're sort of like the jack of all trades, but we're also expected to be the master of everything as well. So it's a very broad field. But we are called on to do things like this. We're called on to help in community fairs, community health centers, research, leadership roles. Often, when you speak, you see people speaking on television, they're often family medicine physicians because there is no topic that's off limits for us. And so, what are some of the most common encounters? Oh, everything. There really isn't. And basically we're the gatekeepers. So everyone with everything comes to family medicine or internal medicine, which is the adult portion of family medicine. And we decide where someone needs to go next. If we can take care of it, we do. If we can't, we refer. Um, and so we do a lot of wellness and prevention. So a lot of, you know, um, I did a lot of gynecology because I wanted women to be able to have a one-stop shop so they wouldn't have to go to multiple doctors for their annual exams. Um, I do a lot of screenings of people when they are at a certain age to make sure that they stay healthy, like colonoscopies, cardiac stress tests, prostate tests. We also see a lot of infections. The bread and butter of family medicine are colds, basically viral infections. So we see a lot of colds. We see a lot of, strep throat, ear infections, and it just depends on the age group as to what infection we might see. We take care of a lot of pain. Now, there are a lot of people who are in a lot of pain, knee pain, back pain, headaches, chest pain. Um, many people avoid doctors and but pain will drive them. People don't avoid us when they're in pain, so we see a lot of that, and we have to determine what the cause is. We also take care of mental health, some people more than others. I happen to do a lot of mental health screening and treatment, like depression, anxiety. When things start getting a little more complicated, then I refer to a psychiatrist or psychologist. But for the most part, most family medicine have a strong background in psychology also, and so we can take care of the basics. Um, Diabetes is another, which is the metabolism issues around carbohydrates. And I'll talk a little bit more about that in just a moment. But essentially, because diabetes is so preventable and it is reversible, and because when it's out of control, it causes such complications, we focus a lot on it. The same with hypertension, which is high blood pressure. Things that can kill people, we tend to focus on. Things that we can prevent that can kill people, we tend to focus on, like screening for cancer, screening for diabetes, screening for high blood pressure, screening for cardiovascular disease, like heart attacks, strokes, artery disease. We can catch those things early. And when we catch them early, we can reverse them. It's only when they go on for too long that we can't. And so we do a lot of watching of our patients. um, Gastrointestinal ailments, reflux, which is basically, or GERD, which is basically heartburn. Deal with a lot of constipation, a lot of nausea, chronic diarrhea, those type of things. Rashes are another thing. Most people don't like having stuff on their skin, so they come to us trying to figure out what's causing it, and we look for that. And there's just so much more. Um, I often would see people also for medication adjustments, for medication management. If they see lots of different doctors and each doctor gives them a different medication, they may come to me and say, "Can you please simplify this regimen?" And I'll do that too. And so, since I mentioned it, I will talk about diabetes just because it is something that touches a lot of us. It is preventable, it is reversible, and but when allowed to go on too long, uncontrolled, it can cause some serious problems. And so I will talk about that a little bit. And what diabetes is the inability to metabolize carbohydrates. Carbohydrates, starches, bread, rice, potatoes, that type of thing. And what happens when we eat carbohydrates is the first thing is our body, in our saliva, we have an enzyme which starts to break down carbohydrates right away. It's called amylase, and it hits carbohydrates. Right. It's the only thing that gets broken down in our mouths. And the reason is that glucose, which is the byproduct, the end product of carbohydrates, is what the brain loves for fuel. In fact, it's the only fuel the brain can use. The other is ketones. I won't get into that, but that's something you can look up. So, because the brain loves glucose, which is essentially sugar, the once it hits your tongue, the brain gets primed. It starts sending out messages to the rest of the body, say, "Get ready, my drug is coming." And that's why sugar addiction is so common because the brain loves sugar. Glucose, when people say high blood sugar, basically it's the glucose in the blood. And so what happens is the carbohydrates broken down in the mouth, it goes to the stomach, it's broken down even more, and then it hits the intestines and it's really broken down and it gets absorbed. Once the message from our mouth to our brain and says there's a carbohydrate coming, it's going to get broken down into glucose or sugar. It sends a message to the pancreas, which is one of our endocrine organs, one of our hormonal organs, that puts out our own insulin. And what insulin does, it's like a key into a lock. And what that key does is it goes to a cell, attaches to the cell, and allows the cell to absorb the blood sugar. When someone has diabetes, they there's two types. There's type 1 and there's type 2. In type 1, the body does not produce enough insulin. And so what happens is there just aren't enough keys to open up all the locks. And so the glucose, the blood sugar, stays in the blood. And that can cause a whole lot of problems. And I'll talk about that in just a moment. But the reason that the pancreas doesn't put out enough insulin is usually because the cells that put them out, they're called beta cells, and they are damaged. And often they're damaged by um, antibodies, our body's immune system fighting against it. And so when that happens, fortunately, we have medication, insulin, that we can give. You often see that in children. We're starting to see it more and more in adults. Viruses sometimes can create this process. Um, it's usually genetic, often, but it is treatable, but it's not reversible. Although right now, I think they are working on a artificial pancreas to help people create insulin in cases like this. Um, And so that's type 1. Type 2 is what's called insulin resistance. And it usually happens in adults. It is usually lifestyle related. You see it very commonly with obesity. The vicious cycle of this is that obesity can cause type 2 diabetes, and type 2 diabetes causes weight gain. So it creates this vicious cycle that, if not stopped, can keep going. And again, I'll talk about the complications in a minute. And so, what this is that we have enough keys, we've got enough insulin, but there aren't enough locks. And so the cells, there's just too much insulin, and they can't get to all the locks to open up the cell to bring the um, blood sugar or the glucose in. That's called insulin resistance because the cells are resisting the insulin that's in the body. And there are medications that are out there to help make the cells more sensitive to insulin so that it can be used and therefore the glucose can drop. However, if this goes on for too long, what ends up happening is the pancreas burns out because it's constantly putting out um, insulin to try and open up those locks, and it can't. Our bodies are full of feedback mechanisms, and I'm not going to get into a whole lot of detail of that, but we are walking thermostats. And so when one part goes out, it throws off something else. We're interconnected systems, and and they work really well together when they work. But if one goes out, it throws off all the others. And so in advanced stages, often what happens, the pancreas burns out and can no longer produce enough insulin, and therefore then insulin has to be given on top of the other medications. And this can cause several complications. And mainly, there are a lot of them. But the one common thing of the complications of diabetes, they are almost always related to blood vessel disease. Blood sugar likes to attach to small blood vessels. And when that happens, it makes them stiff, it makes them hard, it makes them close down. So wherever those blood vessels go, what are called end organs, wherever they go, those organs are not getting enough blood, and they start to shut down. And so one of the things that happens are strokes because the blood vessels in the brain become stiff. Blood doesn't get to the brain. That's a stroke. It causes blindness because it doesn't get to the eye. It causes tooth decay because it doesn't get to the gums. Heart disease for the same reason. Nerve damage, tingling, numbness of the fingers and toes. Kidney failure. And sometimes they happen once to just one organ. Sometimes it happens to several. Once that happens, though, it's very, very difficult to reverse. But again, diabetes can be prevented and it can be reversed. So we spend a lot of time educating, a lot of time checking to make sure we catch it early so we can stop it. And the other that I see a lot of that can be treated is high blood pressure, hypertension. And what that is, it's the pressure of circulating blood against the walls of blood vessels, and it's related to heart pumping. Now, the reason treating hypertension is so important is because pressure damages things. If you think of pressure washing and what pressure washing will do to the side of a house, or when pressure washing your car and how it gets dirt, imagine doing that to the inside of blood vessels. It just shears off the inside. It makes them weak, and it makes them not function as well as they should. And so we use what's called, and I know I'm going to mess this up because I'm trying not to, is a sphygmomanometer. And what that is a blood pressure cuff. And most doctors, if you ask, they pause and say, okay, let me think about how to say this because it is a bit of a word. But that's a blood pressure cuff. Wonderfully now, you can buy them over the counter. So you can get a blood pressure cuff anywhere and check blood pressure. And what the numbers are, the upper number and the lower number are the systolic and diastolic. And what the systolic is basically the pressure when the heart pumps. When the heart pumps, it pushes blood out, it goes through the vessels, and You register that number of how much pressure there is. The diastolic, the lower number, is when the heart fills. So all the blood vessels to the heart are closed, it's just filling up. And so there's sort of a back drag a little bit in the blood vessels. And that's the lower number. And a normal blood pressure is 120 over 80. We like to see it about 120 over 80 or a little bit less. High blood pressure is 140 and above over 90 and above. And so we generally check, we'd like to check blood pressures each year and start to treat early. There are different things that people can do to try and lower their blood pressure, like exercise, like watching their salt intake, watching their cholesterol intake, like with meat, red meats, and such. But we still don't know the cause of high blood pressure. We do know that there's a genetic component, that it's hereditary. We also know that it's lifestyle related. And so we tend to check it often. And that's why you get it checked every single time you go to the doctor, because if you catch it early, you can do something about it. And again, if you notice, the complications of high blood pressure, if left going for too long, are almost identical to diabetes, heart disease, blood vessel hardening, stroke, blindness, kidney failure. So imagine if someone has diabetes and hypertension, that combination is often deadly. And so we work really hard to prevent it, and to get it under control. Where's my, so, um, so that brings me to a day in the life of family medicine. Um, because I'm in family medicine and because I have embraced all the different aspects of family medicine, I've done several things within family medicine. So my first initial jobs were in community health centers. Those were mainly because I had, like I said, I had that obligation, and so I worked in areas that were underserved, for people who often didn't have um, access to community to healthcare, and that was perfect for me because that's exactly what I wanted to do anyway. And so I used the biopsychosocial approach often, because it wasn't enough just to say, okay, you have diabetes, I'm going to give you these pills, take them and come back in a month or 2 months, 3 months. Um, because often what happened is people would come back and they would still be uncontrolled, their hypertension being uncontrolled, their diabetes under out of control, and I would be scrambling trying to make sure that they didn't have complications from these things. But it was often my job to figure out why, and it was rarely the same reason. For some people, it was because they're like, uh, I don't care if I die from this. And so it's what I call, death by slow suicide. So when people would do that, I asked, well, what's going on? I would check them for depression, because people who are depressed don't care. And so I found that if I checked for depression, they were depressed, and I focused on their depression, it fixed that problem. They would take their medication, and then their diabetes and their hypertension would suddenly become controlled. Other people um, would lose their insurance. So the medications they were taking would, all of a sudden, they couldn't afford them anymore. And they might be too embarrassed to tell me this. So I always ask, is there a reason you're not taking your medication? Is there something I can do? So when someone would come to me and say, well, this medicine worked for me, but I can't afford it anymore, I would find a cheaper alternative. I would find $4 medications, because pretty much there are lists out there of $4 medications that do just as well as the $400 medications. And so I would many times take people's regimens that were highly expensive for them and get it down to $18, $20 a month. Sometimes it was illiteracy. I see that often. And it's something that is more common than I think many doctors realize. And what would clue me in is when people would describe their medications by the color. If they told me something was a certain color, I knew that they weren't reading the label. And so when I said, are you taking your blood pressure medicine? Which one is that? The blue one or the red one? That would clue me in. So what I would end up doing is drawing charts with moon, sun, to let people know when to take it, morning, evening, and I would draw the color of the pill and let them know so they could use that chart. And it was visual rather than by words. Sometimes it was side effects. Um, there are many, many side effects to medications. Anyone who's watched television, who has listened to, you know, if you have XYZ, sudden death, these are the side effects of this medication. Tylenol, side effects of Tylenol is liver failure. So, but sometimes the side effects are more immediate and they cause problems, and it makes people difficult to just live their regular lives. So they'll stop taking the medication. And when that happens, we just try to find alternatives. Um, I'd mentioned before, we also sometimes it's because they have too many medications and it's just too confusing. The regimen's too confusing, and we have to simplify that. And then when it's lifestyle related, that's a little more difficult because some people just don't want to stop doing what they're doing. And when they do that, it gets to a point where sometimes we just say, you know what, when you're ready to make a change, call me. After while doing community health, the other part of family medicine that I did, and you'll see this often, is hospice. I was a hospice medical director for many, many years. And what hospice is end of life care for people who are dying. Um, and so, what my job was to make sure that the families, the person, everyone got what they needed in order to make that transition comfortable. So, I would often do home visits. I would do physical exams. I would manage medications, and there are often pain medications. And this is really important to manage because, especially now, I'm sure many of you have heard about the OxyContin abuse or people being addicted to pain meds. Often, what happens when people know someone's on hospice, they will attach themselves to that person because they know that they're getting pain medicine. And so it's our job to make sure that that medication doesn't go down more quickly than it should. We prescribe it for a certain number of times a day for a certain number of days. And so we have to often count pills just to make sure someone's not coming in and stealing it. Um, Especially since many of the people that we take care of were bedbound. So they had no way of knowing. They had someone else caring for them, giving them medications. Sometimes we find out people are switching medications out. Um, but I mean, that's not common, but those are some of the things, the social part of biopsychosocial we'd have to pay attention to because it wasn't all about uh, just treating a specific disease. And so again, mentioning it's end of life care and coordination, family dynamics management, um, because you'd often have children, ex-wives, present wives, um, all arguing, or husbands, all arguing about what should be happening with this person, especially when they weren't in a position to speak for themselves. And we'd also coordinate emotional support. People who are caregivers are under a lot of stress. And so we try to figure out ways to relieve that stress, get them, a bit of a break, make sure that they weren't deteriorating. Um, and so um, the other part of that is also um, compartmentalizing and making sure that we aren't as badly affected by um, oops, by what's going on because it's a lot of death. You get attached to people, they die, and you have to figure out ways of dealing with that. And I'll just go through these a little bit more quickly. I guess I don't want time to run out before a question and answer. So the other part I did was urgent care, which is very much like an emergency room with urgencies rather than emergencies. At least we like to hope they weren't. But we still saw a lot of emergencies like, severed fingers, heart attacks, and that type of thing. And in those situations, it's very much like the day to day in family medicine, except you have to do everything a whole lot faster. Um, and so I'll just read through these quickly. A differential diagnosis determination, you have to figure out what's going on very quickly and start eliminating things. Managing people's emotional reaction to illness. There are a lot of people come in, they're sick, but they don't want to be. And so they're angry. Um, Managing treatment expectations because now with Google, we often get a lot of people coming in telling us what to do. And so we're like, no, that's not how it works. Um, and so also the other is lack of continuity. You don't see the same people all the time. And so that can be difficult for someone who likes establishing relationships with their patients. And now I am a health, wellness, and weight loss coach. And the reason I do that now is because of COVID. I closed down my office. I have my own health issues that I have done worked very, very hard to get under control, and I didn't want to lose that. And putting myself at risk in COVID would have done that. And so what I do now is I help people prevent illness. And so I help because weight is so tied to a lot of the things that I mentioned, obesity and diabetes, obesity, hypertension are often tied. Helping people lose weight helps them prevent further complications. And so that's what I do now. I help people get from point A to point B a lot quicker using my expertise and my knowledge and help them stay there. But it also gives me complete autonomy um, of my schedule, um, and I get to do the part of medicine, the supportive part of medicine that I enjoy the most. And so, let me see, where are we? Can't find my cursor. There we go. So, as I said, I worked very hard to get my health under control. So I practice what I preach. That to me is the most important part of family medicine. You can't tell someone to do something if you're not willing to do it yourself. And so I lost weight. I got off insulin. I was a diabetic. I still consider myself a diabetic, just not on insulin. Um, and I create a program to help other people do the same. And so, and now actually with COVID, which has been very nice, is that I can do it online. And so I can help people all over the world. And so that's what I'm doing now. And so, advice quickly. Um, don't take advice from people who haven't done it. There are a whole lot of people out there who tell you, oh, to do this, you got to get to med school, you need to do this, you need to do that, you need to do this. And you ask them, how many times have you applied? How many times have you gotten into med school? How many times have you graduated from med school? Well, I didn't. Well, then they can't tell you what to do. Know that it's a marathon. It's not a quick thing. You need stamina and you need consistency. It's You're not going to be perfect all the time because there are classes. Some people may fail classes. I've failed classes. I know people who claim they've never failed classes, but they have. Some we do better than others. We all make mistakes. That we're not going to be perfect, but that doesn't mean anything. I can't remember the test I took that I didn't do well in. In what was it? Biochemistry, I think it was. Who cares? I'm a good doctor. I know I'm a good doctor. My patients know I'm a good doctor. They don't care what my grade was in biology 101. So they just want me to be here. Surround yourself with supportive people. There are a lot of naysayers out there. There are a lot of people going to pick at what you do. So you want to be around people who are going to encourage you and say, yes, you can do it, because there's going to be more than enough people telling you you can't. And those are the ones you need to eliminate or at least avoid or ignore. The other is have a hobby. Don't let pre-med, getting into medical school, being a medical student, being a resident, don't make that your whole life. You have to have something that's separate. For me, it's music and art. Um, Now I have a family, I have children. All those things matter more to me than medicine. I enjoy it, I love it, but when I need a break, I have something. And the other is stay healthy. When you're not healthy, you can't help people. Um, so eating cleanly if you can, exercising regularly, having a regular exercise regimen will probably be one of the best things you can do for yourself to get through medical school and for stress relief and for just general health. So, questions. Ooh, 45 minutes. Um, so you'll have to read the questions to me because I am not
Mhm.
connected. So if you can just let me know if anyone has any.
Definitely. So if you guys have questions, feel free to put on the chat and I'll read them aloud to Dr. Toomer. Mm. So I'll start with a quick one. So your journey is like pretty like not like a traditional from college to medical school, and then you took like gap years. Like,
Mhm.
how did that like improve? you as a person, and just how did it help to, like, I guess, like, make medical school a lot easier for
Mhm.
you?
What it did, what I was a little older when I started, so I was
Mm-hmm.
27 when I started med school. One of the things I didn't mention is that in my junior year, actually, of right before my junior year, I was in a car accident and I had a head injury. And so I actually slowed down considerably um, while I was preparing for med school.
Mm-hmm.
That that I was older, that I took a gap year. What it does, it makes you more interesting to med schools. They really like people who've lived life. And so when it came time for me to write my personal statement, when it came time to talk to people, it wasn't all about I took chemistry and I got an A. I took this and I
Mm-hmm.
got an A. I did, I traveled. I homeschooled my niece for a little while. I took a
Mm-hmm.
gap year and, took classes that were just interesting just because, not for any reason other than I just wanted to. Um,
Mm-hmm.
and so all those things make you more interesting. All life experience makes you more interesting. And so there is no time limit. Many people I actually had someone in my class who was 61 years old in my med school class. I had other people who had whole careers in finance and decided to go to med school.
Mm-hmm.
So there is no timeline. There's no, um, you don't have to do it in a linear fashion.
Thank you. Um, so let's see. So we have a question that says, so is family medicine the first step to every medical process?
No.
No. Mm-hmm.
What happens is when you're I knew before I started med school what I wanted to do. Most med
Mm-hmm.
students don't. They go to med school and they figure it out as they go along. Some people actually finish medical school, go through residency, and still change because they're like, okay, this isn't what I thought it was. I'm going to change to something else. One of the things, the only field of medicine that is like sort of a stepping ground. Well, actually, that's not true in medicine. For like in family medicine, if I wanted to, I could specialize in sports medicine.
Mm-hmm.
I could become an OB track and do cesareans and deliveries. I could do focus only on adolescent medicine. That's fine. Then you have internal medicine, which is basically just the adult part. You just see adults. From there, many residencies, many other fields require a year of that. So you'll do a year of internal medicine, then do surgery, or a year of medicine, then do radiology, a year of medicine, then do dermatology. And so it really just depends on the residency program, what they require. But, you know, family medicine is not a requirement, but you can do a year and then go off and do something else. But it just depends on what I think now pretty much everyone expects you to have a preliminary year, which is either family medicine or internal medicine before going on to specializing in something else.
Perfect. Thank you. Another someone asks, like, what's your favorite part of being a family medicine physician, and any least favorite parts?
Mhm. My favorite part is when people when 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 people come to me and they say, I don't know what's going on. I've gone to doctor to doctor to doctor and I can't figure it out. And then I'm able to figure it out. That's my favorite part. And just the relief of being able to help someone get their life back. That is my absolute favorite part. Um, Giving people their lives back. And I don't mean like, taking them from the dead and bringing them back to life, but a life that they can enjoy now, um, or that they appreciate, that they, suddenly can start playing with their children again, or, enjoying going for walks, or going to back to a hobby they couldn't do because something was going on. That's my favorite part. My least favorite part is Google. I'll be honest. Although it's nice because it does help patients advocate for themselves, but up to a point. Um, Google has made it very, very difficult for people to respect physicians and physicians' decisions. And that frustration starts a vicious cycle of distrust and back and forth. And so I have to say, my least favorite part is when someone will put their Google search above my years of education.
Thank you. Someone says, any advice on succeeding medical school?
It really is consistency and daily activity. Um, and having a sense of who you are. You can't let medical school define you because it is somewhat of a hazing process. There are people in medicine who are miserable, and there are people in medicine who aren't. The miserable ones seem to come in contact with med students more than anybody else. And no, I'm just joking. Not terribly, but there are people who just are not very nice people, and you have to remember that one, you're paying for it. So this is your process. The other is that it doesn't make you who you are. The third part is um, you don't have to be perfect. There is no such thing as a perfect medical student. There are people out there who will try to tell you there are things about being a medical student, but if you ask them, they weren't that person. So, there really is consistency in studying is another, enjoying the information. I mean, really enjoying the information helps. If you don't enjoy the information, then you're probably in the wrong place.
Awesome. So I think another question has to deal with like imposter syndrome. So
Hmm.
someone says, like, during your pre-med journey, like, did you have any doubts that to become like physician in
Of
general?
course, everyone has doubts. And
Mhm.
anyone who tells you they don't, they're lying. I mean, everyone has doubts about something. And one of the things I actually have tried to avoid, imposter syndrome, I think is being overplayed. I think that what is doing is being used to actually create imposter syndrome. Everybody has doubts. That doesn't make you any different. It doesn't mean that you have something wrong with you. It doesn't mean that you have some component of your psyche that you suddenly have to fix. There's always going to be doubt. There are always going to be people who tell you can't do it. You just do it anyway, and you do it scared, and you do it with that doubt. And the thing is, sometimes that doubt won't go away until you're out of residency and you're working and you have a patient who hugs you and cries and says, "Thank you. I'm so happy you're here." Because all through the process, there are going to be people telling you you don't belong here. So my thing is, who cares about imposter syndrome? If you have it, it doesn't matter. You're still going to do what you want to do. Just do it.
Awesome. Let's see. We'll wait a couple more minutes because I think we have
Okay.
still about 5 minutes or so.
Okay.
If people have any questions that you guys want Dr. Toomer to answer, please put it in the chat. Um, but it was really interesting to see that your least favorite part was people using Google because I've seen a lot of memes on that. Just
Yeah.
really
I
funny.
mean, I think Google is very helpful. I think
Mhm.
WebMD gives, every headache is brain cancer. Um, but it does help. I mean, now it does help in some ways. 'Cause, I mean, it's important to be your own advocate. So if you know
Mhm.
something's wrong and doctors keep telling you nothing's wrong, you can use Google to try and get to the answer. Use, Facebook groups and whatever. But, when it's something basic, like someone who says, "I think I have appendicitis."
Mhm.
Appendicitis is a pretty straightforward diagnosis. And so you can pretty
Mhm.
much say, that's the wrong side of the body. I'm sorry that Google informed you that you might have uh, appendicitis, but that's not where the appendix is on your body, that sort of thing. So, and there are people who just will refuse to listen. And then there's
Mhm.
others who will, but it's also our job to explain things in a way so that they make sense. So my thing is, if someone Googles and they come to me, it's a teaching moment. I can just teach and say,
Mhm.
okay, these are where your organs are in your body. So the next time you have a pain here, this is where you should look in Google, not over here. So it can be used to a patient's advantage, but
Mhm.
um, I think that it has chipped away at some of the respect that physicians receive for their knowledge. But I think that physicians have reacted to that with hostility. And so it just creates this vicious cycle of distrust, hostility, distrust, hostility. And
Mm,
so I think that that's something that both parties have to break.
interesting. See. Alrighty. So if you guys don't have any more questions, I would like to begin thanking Dr. Toomer
Okay.
for taking her time and coming here to talk to us. It was
Okay.
really
I'm just
informative
gonna put
and
up my oh, I should
yeah,
have put the
definitely.
information up. Listen,
Hmm.
I love, as you can tell, I love to talk, I love to teach. Anyone who has a question about anything related to pre-med, really anything, because I take care of everything. Um, I won't do any medical diagnoses, obviously, but I can point you in the right direction. But you can contact me on Facebook. You can contact me on Instagram. You can contact me on Twitter. Catherine Harmon Toomer, MD. I'm the only Catherine Harmon Toomer, MD that there is.
Hmm.
There are other Catherine Harmons, there's other Catherine Toomers, but I'm the only Catherine Harmon Toomer, MD. So find me, ask me. I have no problem, and is no question is stupid. I've done it, and I am the perfect person to ask how to do it. So I don't mind. Just contact me.
Okay. Oh, quick questions. What is the one thing that you knew before starting your medical journey?
How did I know that what I wanted?
Uh, just one thing that you knew before you
Oh,
started
one
your
thing that
medical
I
journey.
knew
Yeah.
before
Hmm.
starting my medical journey. I knew that I wanted it, and that's all that mattered. It really is. You have to want
Hmm.
it, and you have to know you want it, because there's going to be doubt. There are going to be people telling you you can't, and you just
Hmm.
have to know that this is what you want. If there's anything else you want and you go for it, do the same for this. Just do the same. And even if it
Hmm.
means getting a master's degree before getting into med school, or getting a job for a little while to pay off student loans or whatever, you just keep your eye on the prize.
Hmm. Awesome. That was like short and sweet too. So, alrighty,
Okay.
perfect. All right,
So
thank
like
you
I said,
again for
anyone can
coming us.
contact me
Hmm.
anytime. Just if you have your question, you think of something later, just contact me. That's no problem.
Okay. All right.
All right.
All right. Thank you everyone for joining. Don't forget to take the assessment for which is posted on Google Chat to get your hour for this session. And also, don't forget to use one email throughout all your assessment because we'll be tracking those hours for you guys. To stay tuned because tomorrow we have another physician who will be talking more in terms of dermatopathology, and it will be at 9:30 a.m. Pacific time. We thank you all for joining our e-shadowing session today. And again, thank you, Dr. Toomer, for coming and talking to us.